Good afternoon, ladies and gentlemen. I'm Mina Kim from Korea University Anam Hospital, Seoul, Korea. I apologize that I cannot attend the Congress in person. We have an emergency heart transplantation scheduled for today, and I should assist with evaluating the transplanted heart function during the operation. Today, my talk is about the pulmonary hypertension and right-side heart failure in liver transplantation. This slide shows the characteristics of cardiac condition that can occur in liver disease. This condition is included hyperdynamic syndrome and cirrhotic cardiomyopathy, hepatopulmonary syndrome, and portopulmonary hypertension. Portopulmonary hypertension is defined as a pulmonary arterial hypertension in the setting of the portal hypertension with or without intermittent liver disease. Portopulmonary hypertension is a rare subtype of group 1 pulmonary arterial hypertension with a poor prognosis. About the prevalence, the registry data suggests that portopulmonary hypertension accounts for 5 to 16% of cases of pulmonary arterial hypertension, and portopulmonary hypertension develops in 1.1 to 6.3% of portal hypertension patients. And liver transplant patients, the prevalence of the portopulmonary hypertension is 5 to 10%. About the survival, without treatment, the patient have a 1 year survival is 35 to 46%, and 5-year survival is very poor, about 4 to 14%, respectively. This slide shows the pathophysiology of the portopulmonary hypertension. The exact mechanism of portopulmonary hypertension is not fully understood, but the generally accepted pathophysiology is that the hepatic injury and splanchnic vasodilation and hyperdynamic status and portal system shunting have all been proposed as a mechanism that increase the production and decrease the clearance of the circulating factors that facilitate vascular remodeling and inducing the imbalance in vasoactive substance. Patients with cirrhosis and portopulmonary hypertension have an increased level of endothelin 1 and interleukin 6, and a decreased level of prostacyclin compared to patients with cirrhosis without portopulmonary hypertension. Therefore, this situation are considered to play an important role in portopulmonary hypertension. Imbalance in vasoactive substance promote vasoconstriction and smooth muscle cell proliferation and platelet aggregation and thrombosis. As a result, portopulmonary hypertension could be developed. The symptoms and signs of portopulmonary hypertension are similar to pulmonary arterial hypertension. Most common symptom is the exertional dyspnea, and the patient could complain of chest pain and palpitation and syncope and syncope. The sign of portopulmonary hypertension is similar to sign of RV dysfunction and hypoxemia, such as a right side S2 gallop and the spirit of S2 sound and clubbing and cyanosis. What do we do if patient with liver cirrhosis complain of dyspnea? Initial workup is the transthoracic echocardiography. As seen here, RV size and function can be assessed and evaluated through the transthoracic echocardiography. Among these, an important parameter is pulmonary arterial systolic pressure, which is determined through the tricuspid regurgitation velocity. Once the pressure gradient between right atrium and right ventricle is obtained using the Bernoulli equation by the tricuspid regurgitation velocity, and it is added to the fixed RA pressure like this, and we can obtain the pulmonary arterial systolic pressure, and it is saying the RV systolic pressure in the absence of the pulmonary valve problem. If increased pH systolic pressure and RV dysfunction existed in echocardiography, we recommend to perform the right heart catheterization. AASLD recommends the right heart catheterization in patients with RVSP over than 45 mm mercury on transthoracic echocardiography, while ERS task force and Mayo Clinic use the RVSP over than 50 mm mercury. The diagnostic criteria for portopulmonary hypertension are as follows. Mean pulmonary arterial pressure greater than 25 mm mercury as measured by right heart catheterization, and pulmonary vascular resistance exceeding 3 Wood units, and the pulmonary capillary wedge pressure less than 15 mm mercury. These parameters are essential for accurately diagnosing portopulmonary hypertension. However, recent World Symposium on Pulmonary Hypertension, the diagnostic criteria for pulmonary arterial hypertension was revised, lowering the mean pressure threshold to 20 mm mercury. Additionally, some recommendations suggest lowering the PVR threshold to 2 Wood units to facilitating the earlier diagnosis. By evaluating parameters such as mean PA pressure and PCWP, PVR, and cardiac arrest by right heart catheterization, we can assess the patient's current condition. If mean pressure is increased and PCWP and PVR was in the normal range, patient condition is a high output status. If the patient developed portopulmonary hypertension, mean PA pressure and PVR was increased, and PCWP is in normal range. The diagnosis of portopulmonary hypertension is made. Its severity is determined based on the mean PAP level. If the mean PAP less than 35 mm mercury, it is classified as mild, and between 35 to 45 mm mercury, it is considered moderate portopulmonary hypertension. Above the 45 mm mercury, it is classified as a severe portopulmonary hypertension. Let's see the management of the portopulmonary hypertension. The true impact of medical therapy on survival and optimal pulmonary arterial hypertension regimen are still unknown. Anticoagulation is not recommended due to increased risk of bleeding, and calcium blocker should be avoided due to lack of established benefit and potential to worsening portal hypertension. In moderate to severe portopulmonary hypertension, withdrawal of beta blocker should be considered along with the alternative method for the prevent variceal bleeding. Because the use of beta blocker can cause the reduction in cardiac output, and in the case of the severe RV dysfunction in portopulmonary hypertension, this reduction in cardiac output can be even more pronounced. This slide illustrates the three major pathways involved in the treatment of pulmonary arterial hypertension, especially in the context of portopulmonary hypertension. The pathways are endothelium pathway and nitric oxide pathway and the prostacyclin pathway. In endothelium pathway, medication like ambrisentan, macitentan, and bosentan target the endothelium pathway by blocking endothelium receptor, which reduces the vasoconstriction and the smooth muscle proliferation. The medications such as riociguat, and sildenafil, and tadalafil target the nitric oxide pathway to promote vasodilation. Ipoprostenol, iloprost, and treprostinil, and selexipag are utilized in prostacyclin pathway to induce the vasodilation and inhibit the platelet aggregation. Let's see the evidence of this medication for treating portopulmonary hypertension. Most of the studies have a very small number of patients, and there are very few randomized controlled trials in pulmonary arterial medication for portopulmonary hypertension treatment. And no randomized controlled trial has been conducted evaluating the use of the PDE5 inhibitors in management of portopulmonary hypertension. Small retrospective study showed significant improvement in the hemodynamic profile like PVR and mean PAP as a functional capacity in the patient, like this figure. Endothelin is one of the most potent vasoconstrictor primarily involved in the pathogenesis of pulmonary arterial hypertension. Therefore, endothelin receptor antagonist, we call the ERA, stand at the forefront of the pulmonary arterial management with proven long-term efficacy and favorable safety profile. So, ERA role might be effective to treatment of the portopulmonary hypertension. This slide showed the bosentan and ambrisaltan had improved hemodynamic parameter in patients with portopulmonary hypertension. And the ambrisaltan is increased the 6-minute walking distance in patients with portopulmonary hypertension. Macitentan is an effective ERA. It currently widely used, and it has a relatively low risk of hepatotoxicity. So macitentan might be suitable for the treatment of portopulmonary hypertension. Puerto Rico trial demonstrated that macitentan reduced the PVR compared with placebo group. About the functional status, the 6-minute walk distance numerically is increased in macitentan treated group, but it could not be shown the statistically significance. Prostacyclin is a systemic vasodilator and a potent androgens inhibitor of the platelet aggregation. On left, in small data, intravenous epoprostenol was improved hemodynamic profile like a mean PAP and PVR. However, about the survival, there is a conflict evidence in the IV epoprostenol. On right, the intravenous prostacyclin, including epoprostenol and treprostinil, increased the survival in patients who did not undergo liver transplantation, and showed the best survival rate in those who received the liver transplantation. This slide shows the recommended combination therapy in pulmonary arterial hypertension treatment. Among them, some combination therapy like ambrisaltan and sildenafil and treprostinil with sildenafil was improved hemodynamics in patients with portopulmonary hypertension. How about liver transplantation as treatment for the portopulmonary hypertension? As mentioned, several mechanisms have shown the improvement in hemodynamics and functional parameters. However, as is in the graph, the best prognosis was observed in the patient who received the liver transplantation. Reported 5-year survival after liver transplantation in portopulmonary hypertension patients is 63 to 67%. It is quite higher than patients without liver transplantation. This trend is evident in this meta-analysis as well. This meta-analysis compared the impact of vasomodulator therapy and LT survival for the patient with portopulmonary hypertension. And 1 year and 3 year and pooled estimated rate and LT is superior than the vasomodulator therapy. Therefore, the most effective treatment of portopulmonary hypertension is liver transplantation. But there are some things that we need to consider before liver transplantation. Liver transplantation is safe for all patients with portopulmonary hypertension because the liver transplantation is induced the reperfusion of the liver graft, and then it induced the pronounced systemic hemodynamic change, such as increasing cardiac output above 300%, and that it is exacerbated pulmonary hypertension, and that it induced the potential right side heart failure. And finally, liver graft congestion and liver flow in hepatic vein could be developed. And this all data shows the increasing mean PAP is closely associated with higher mortality after liver transplantation. If the mean PAP over the 45 or the 50 mm mercury, the mortality rate is about 100%. Therefore, the liver transplantation planning for the patient with portopulmonary hypertension is important. Mean PAP 25 to 35 mm mercury, PVR over the 3 would indicate good right heart function, start the pulmonary vasodilator therapy, and placed on the transplanted list and reassessed every 6 months. And the patient have the mean PAP 35 to 45 mm mercury over PVR is 3 unit. If RV function is poor, the deeper transplant and the start of pulmonary vasodilator therapy, and then mean PAP and PVR should be reassessed in 6 months. If RV function is good, then stress RV test with the dopamine or fluid challenge. It still good, then place on transplantation list and start on pulmonary vasodilator therapy. Mean PAP is over the 45 mm mercury and PVR over 3 would you need, and defer the transplant and start the vasodilator therapy, and these parameters should be assessed in 6 months. But there are some limitations in treating and prescribing pulmonary arterial hypertension medication, vasodilating treatment in Korea. Tadalafil and epoprostenol, riociguat, were not commercialized in Korea. Almost medication except sildenafil and valsartan was not indicated for treatment of portopulmonary hypertension in Korea. So we do not have many weapons. In summary, portopulmonary hypertension affects 5 to 10% of liver transplanted candidates. Initial screening with echocardiography is recommended for all prospective candidates. The measurement of pulmonary arterial systolic pressure by right catheterization is recommended in patients with increased PSP over than 45 mm mercury in transthoracic echocardiography. About the management, mainstream is the pulmonary arterial medication before and after liver transplantation. But there is some limitation. The evidence of pulmonary arterial medication for the portopulmonary hypertension treatment and medical environment of the use of pulmonary arterial hypertension medication is very limited in Korea. Thank you for your attention, and I'm very sorry for I cannot attend in person once again. Thank you for your attention.